Hello, and thank you very much for joining us on Upfront on Journey. So, for many of you who've been asking the question, what does it mean to say Ghana has reached COVID-19 peak? And also, how we're able to calculate this, knowing that there are many concerns about real-time data on a number of infections. So today, we want to understand how Ghana has reached COVID-19 peak and also understand what that means for our fight against COVID-19. You know, when you reach peak, it means that you've actually reached, the highest point there, as you could see in that particular, graph or bell-shaped diagram. Means we've reached the peak, and thus expect a decline in the number of cases. Now, that certainly should be good news for all of us, because once we've reached our peak and we're expecting a decline, it means that all things being equal, very soon we're going to be out of it. We're going to be excited as a nation that at least we've been able to deal with COVID-19. So today, I've assembled some persons with expertise when it comes to, how you can actually calculate, the numbers and determine how we've reached our peak. And so we've been joined by Dr. Emmanuel de Graaf Johnson. He's actually with the Department of Mathematics and Statistics and Actuarial Science at the Kwame Nkrumah University of Science and Technology. And we'll also be speaking with Dr. Michael Owusu, who is a virologist at the Kumasi Center for Collaborative Research. But before we get into all the discussions, and let me say good evening to all of you gentlemen, thank you very much for joining us. But Dr. Baidu Sarkodie has been talking about how Ghana has reached its peak when it comes to COVID-19. Watch him talk about how we've reached our peak, how we calculated it, and then when we get into the studio, we get into a conversation about how we got there and what models were used.
We started having a build. The first confirmed case in the country was on the 12th of March. Since then, those were from the people that we put together later, those that were put on quarantine. Out of the 1,030, within a short time, we had 115 of them. Those in quarantine at Accra here and also in Tamale. So we realize that with a sharp rise, and now with the cases that we are tested, clearly we seem as a country to be on top of the peak, and we are at the stage to decline. That is the observation now. The declination will depend on how we adhere to the various preventive etiquettes that have been enumerated. We are not off the hook yet. But then if we continue the way we are doing now, by adhering to the various social distancing, adhering to the various individual preventive measures, wearing of mask, keeping away a distance from others, hand washing, cough etiquettes, other respiratory etiquettes. These are the things when we do intensively will let us come down from where we are. So responding directly to the question where you are at the peak of the curve, yet to come down. But then the only thing to make us come down by strict adherence to the various preventive etiquettes.
Well, so that's Dr. Baidu Sarkodie, who is the Director of Public Health at the Ghana Health Service. We'll go for a short break. When we return after the break, we'll be joined by Dr. Emmanuel de Graaf Johnson, who is at the Department of Actuarial Science and Statistics of the Kwame Nkrumah University of Science and Technology. Now, he's come up with a mathematical compartmental model. That model would actually help us understand how we calculate, Ghana's reaching of peak status when it comes to COVID-19. I'll also be speaking to Dr. Michael Owusu, who is a virologist at the Kumasi Center for Collaborative Research. They've been testing, and he'll be helping us to understand whether they've had their highest case and actually beginning to see a decline as expected once we reach peak status. My name is Winston Amoah, and this is Upfront. We'll be right back after the break. All right, so welcome back from that short break, and thank you very much for staying with us. This is Upfront on Joy News, and I am Winston Amoah. So I told you earlier that we've been joined by Dr. Michael Owusu, who's a virologist at the Kumasi Center for Collaborative Research, and then Dr. Emmanuel de Graaf Johnson, who's also at the Department of Actuarial Science and Statistics of the Kwame Nkrumah University of Science and Technology. Now, they've joined us because they have expertise in, what we're about to discuss. Dr. de Graaf Johnson has actually developed a model that is used in calculating number of cases and determining whether we've reached peak status. So, Dr. Usu, Dr. de Graaf Johnson, thank you very much for joining us. And starting off with you, Dr. Usu, you certainly should be a happy man now, knowing that, our cases will begin to decline and that we're getting out of COVID-19 shortly. And also the joy that people would not be affected so much by this virus, right? Hello, Dr. Usu. Yes, Dr. Usu, can you hear me? Okay, so I certainly would get back to you, Dr. Usu. Let me get to you, Dr. de Graaf Johnson, because I know that you've actually developed this mathematical compartmental model that is used in calculating COVID-19 cases and also determining whether we've reached peak status or not. Help us understand what the model is all about and how it works.
Okay, when it comes to compartmental models, it helps us to understand how the flow of spread of diseases actually do happen. And this one can be used both in any of the infectious diseases as well as in the pandemic situation as we have right now. Now, when it comes to modeling epidemiologically, basically what we try to do is you have to first get a scientific understanding and the precision in the expression of the current theories and the concept that actually mimic and describe the problem we have at hand, and then to be able to identify areas in which better epidemiological data is required to refine the prediction and improve the understanding.
So, Dr. de Graaf Johnson, we will try as much as possible not to be very technical so that all of us can have an understanding of it. So, let's look at, moving away a little bit from all the technicalities of it. Let's look at how that model works and the various forms that the model is in.
Yeah, actually, the model itself is what we call the SEIR model, which is the basic form of the model. But in this case, due to COVID-19, we have to modify it to give us what we call the XEIARD model, where actually the letters start from, you have the X being susceptible, then you have the E being exposed. The exposed being the subpopulation which will be exposed to the infection or to COVID-19. The susceptible will actually be everybody susceptible to this particular diseases. And then you move on to have what we call the infected population. The infected population are they are generated at a proportion from the exposed class because they've been exposed to the diseases. And in this one, we have two main types there. We have the infected population that are symptomatic, means they do have some kind of symptoms associated with the diseases. And then the one that we have asymptomatic. Those are the people that they've contracted the virus, but they don't show any kind of symptoms out of that. And then from this, we have the movement that they also move. From either infected, they can become recovered or they can die because their disease model might progress to severe, or some will come back and recover entirely from the disease.
So at this point, let's just hold on. Let's just hold on. Dr. de Graaf Johnson, let's hold on at this point. We'll come back. So when it comes to the susceptible, for instance, since you say that means the general population, by way of understanding, are you saying that for those who are susceptible to this disease, we're looking at the totality of Ghana's population?
Exactly, that's the point.
Okay, and then when we come to exposed, how do you get the figure that you say is exposed?
Okay, when it comes to exposed, the way we get the figure is this. Example, if you look at the Ghana Health Services, the work that they're doing, that means that if somebody comes, is being identified and diagnosed for a confirmed case of COVID-19, it means that all the persons that he has come into contact with it are classified as being exposed. So they have to do this contact tracing, and they have to do this enhanced contact tracing to be able to identify these particular individuals and quantify them. That's the reason why they're able to tell us that this is the number of samples that we've done, because these are the people that they have gone after them, and because they've been exposed to somebody who has a confirmed case.
Okay,
so that is how the exposed is being calculated.
So talking about the exposed case, now you talk about how you use data from the Ghana Health Service, and that'll be the contact tracing, and maybe other surveillance. How do you know that this number is actually a number of persons who've been exposed? How do we verify that this is the right number?
Yeah, how we verify this one is this, because you must be able to understand the virologists, and you should be able to understand the epidemiologists, what they say about the diseases. World Health Organization and CDC has given us a lot of information about that. So, for instance, if we are told by Ghana Health Service that this is the number of people that they've been able to contact because of their coming into contact with an infected person, then you know that is the exposure. Okay. So if Ghana Health Services comes out to tell us that we've able contacted 15,000 people, then you know all these 15,000 people will be classified as exposed. Okay. Until the Ghana Health Service conduct the test. And then when they conduct the test, they'll be to tell us the number that out of these 15,000, about 17 or 18 or 19 are infected. Okay. So that is how you move from one compartment onto the other compartment. And you do this calculation to move on with the model. So
let's move to the symptomatic and asymptomatic. You say the symptomatic would either recover or die, and then, you know, the asymptomatic would recover because they are showing no symptoms, right?
Yeah, precisely. Now, when it comes to symptomatic, if you listen to the data that they give out, they are able to clearly tell us how many people are hospitalized. They will tell you these are the number that are in the hospital. If somebody is in the hospital, it's clear that the person has shown some kind of symptoms. Okay. They also have what we have to be case isolation, where you put them in isolation centers. And then they have the ones that they are actually kept in the houses. So if somebody is kept in their house, then it is assumed that the person becomes asymptomatic. So they will allow the person to be in the house, monitor the person day in, day out, and check on the condition of the person, giving all the protocols that they have to be able to follow. This is how we move on into an infected population. Either it is symptomatic or either it's asymptomatic.
Okay. Now, having determined the symptomatic population and asymptomatic population, then what happens?
Then you have to move on, because you should be able to actually do some kind of calculation, because a lot of literature and a lot of work which has been shown worldwide, as well as WHO, indicates that if you have a certain number of infected people, about 90% of them will be asymptomatic. So you should be able to move on to the next stage. The next stage is this. The next stage is that if you look at the symptomatic, which is the infected symptomatic, then it's either the person can recover or the person dies. That is the issue here. And when it comes to the asymptomatic, as far as we are speaking, we don't have any evidence to show that anyone which is asymptomatic has died. Ghana Health Service has not given us that particular data. So those that are symptomatic will be recovered or they will die. And now if I have, say, 500 people who to be symptomatic, and then I still have about 18 of them still say they are symptomatic, then the question is how many people have died? If I know the number of people who have passed away, I can subtract it from my compartment of symptomatic patient, and given the active cases, the symptomatic patient, I can know my recovery. So the recovery data that
can you go through that again, and so we can have a better understanding? So if you know the number of people who are asymptomatic and number who have recovered, then what happens? Yes.
Yeah, if I know the total number of people who are symptomatic, and if I know the number of people who are moving from symptomatic into death, then at least the compartment has reduced. So if I still do have a certain number at point of time, which is less than the previous one, then those numbers would have been recovered. So from the symptomatic compartment, they will move to either death or they will move to recovery, all those who have not recovered or they have not died will still remain in that particular compartment.
Okay.
And that is how the rate of movement is being calculated for you to be able to come up with a refined ratio or the rate of which they move from one compartment to the other. For the asymptomatic, it has to do with only recovery.
Okay.
So either somebody who is asymptomatic recovers, or the person has not recovered, but he has not shown any symptoms. So he still remains in the asymptomatic compartment.
Okay. So when we have established all of these things, so we know the numbers that are symptomatic and have recovered, and those who have also died, and with the asymptomatic, those who have died, then what happens? What is the significance of, these numbers?
The significance of this is it helps you to be able to know whether your incoming cases and your outgoing cases are stable or not. For instance, if more people are moving to the compartment where less people are moving out, then you know that you are going to burden your hospitals. So, example, if more of the symptomatic case comes to grow up and up and up, then you know that it's going to put much demand on the hospital because more people move into hospitalization. Okay. Now, when it happens that you have lesser number, which is moving from the susceptible to exposed, then you know that your controls are actually working and your mitigation measure are becoming much more effective.
Okay.
That is how the movement actually tells us. Okay. Now, in the other way, if you have more people moving out of the compartment, becoming recovered, or they are recovering from it, and less people moving in, then it means that you have control over the disease now. That is the understanding of it. Because you have more people moving out, it means that your therapeutic measures are working, and then your mitigation measure to actually stop it are also working. So these are the kind of information we need.
So we will get to the Ghanaian situation shortly. But before we get to the Ghanaian situation, we also do know that there are some measures that are put. You also, analyze the measures that have been put in place. In analyzing the measures, what do you look at?
Okay. In analyzing the measures, these are the things that we look at. First, the compartmental model will be able to give you what you call the reproduction number. And the reproduction number is the number of secondary infection. That means that if I'm a victim or if I'm infected, how many people can I transmit it to? This is the number that every epidemiologist, medical health practitioners, and Ghana Health Services wants to bring it down. Okay. That is what determines the bear peak that you're talking about. Now, we have to move on to get what we call effective reproduction number. The effective reproduction number is putting the measures, and the measures are two. We have what we call mitigation measures and suppression measures. The mitigation measure aim at actually not eliminating the diseases, but what you do is that you want to spread it, prolong it. And when you are prolonging it, the peak number is coming down. And when the peak number is coming down, it means that you will not have much more demand on your hospital, on your hospital facilities. So you prolong it. So if it will take us maybe 3 weeks to hit the peak number, then if you put in the mitigation, you prolong it. Instead of 3 weeks, it's going to 5 weeks, but the number will be reduction, such as case isolation, that if you find somebody who has been confirmed case, we isolate the person in order for the person not to infect other people, such as closing of schools, because when you close schools, the activity of interacting, the social compact nature interaction between students will reduce. So, for instance, my son or my nephew who goes to school will not meet anyone whose family has been infected and bring it back home. So that kind of reduction actually takes place. Then you have the quarantine. The quarantine is that the person has been exposed, but he's not confirmed. So if you know I'm being exposed, I'll be told to quarantine myself within a specified day for which Ghana Health Service will come and conduct the test. If they conduct the test and it proves positive, then I have to move to isolation. If it proves negative, consistently based on their protocol, then what it means that I don't have it. So these are the ones that we put into place. The other one has to do with what we call the death. When somebody dies out of COVID-19, how do we process it? Do we give it back to the family, or government has to handle it?
I would come in at that point and ask you a very simple question. So, this is a model you have developed. Have you given this model to the Ghana Health Service?
What we are doing right now is that when we come out with such a model, what you do is that you host it, you publish it, you give it to people who matters, and then you discuss it as we are discussing right now.
Have you given it to the people who matter?
Yes. So, giving it to the people.
Go ahead.
Giving it to the people who matter involves this. For instance, when it comes to the modeling community, World Health Organization and CDC give us a very special platform that you can host it. So you host it on the platform, and then we know that the Ghana Health Services, we know that the Ministry of Health do have people who actually also looks at that. So that is how we spread this kind of information that we have into the community, for the scientific community, academic community to come and embrace it.
Yes, but I want to be specific. So you hosted it on the World Health Organization platform, and you expect the Ghana Health Service to have had access to it, or you gave it to the Ghana Health Service, and so you know that, okay, so the Ghana Health Service has access to it.
What do you do? What do you do is this, because models goes through what we call review. And review are from expert people who are in this world of modeling. For this case, let me put this one. It was hosted at archives.com, which is the Cornell University COVID-19 response research work. So when it is hosted there, then we send it across, we share it, the information. And that is how the community, the academic community.
So would I be right to say you've shared it with the Ghana Health Service?
For now, because I have not spoken to the Ghana Health Service personnel, I cannot confirm that. But what I can confirm is that it is hosted on the web by Cornell University Archives.com, of which everyone can have access to it. That is the medium that we,
and so have you informed the Ghana Health Service about this?
No, I have not informed Ghana Health Services about this, because it is academic work that when we do it, what you have to do is that you should be able to propagate your findings, and then when your findings catches attention of authorities, then you speak to them. That is how models that we could actually work.
Based on this model, are you able to calculate Ghana's case and determine whether we've reached peak status?
Based on this model, if you understand the theoretical understanding of the model itself, the answer will be yes. But the question is that what kind of data is Ghana Health Service actually also giving out? Because the data that you use for this particular kind of model has to do with what we call daily incidence data. But as we speak, we do not have daily incidence data from Ghana Health Service. We do have cumulative data from Ghana Health Service. So we pray, and then we know that Ghana Academy of Arts and Science are actually put up a team working with them. When they're able to give the incidence data hosted at the Ghana Health Services website, then we'll be able to use our models, evaluate the data that they'll be able to give it to us, and those specific answers as you ask could be answered from there.
So are you able to say, for instance, that Ghana has reached peak status when it comes to COVID-19?
Without incidence data, I cannot make that confirmation. Because when we say Ghana has reached peak, this is what it means. It means that your data from start will be increasing to a point. At that point, your incidence data becomes much more stable, means that the increment will be highly significant. Example, if your incidence is 20 today, it could be 20 tomorrow, or it could be 21 the next day, it could be 22 the next day, then it comes to 20 the next day, 19. So you see, the incidence daily data will increase to that point that we call the turning point plateau, then begins to decline as the days goes on. Now, the only way for me to be able to evaluate this is if you have access to the incidence data.
And talking about the incidence data, now you talk about how the Ghana Academy of Arts and Sciences as a team working with the Ghana Health Service. You're part of the team?
I am not part of the team of the Ghana Academy of Health, Ghana Academy of Arts and Sciences. But what we do is that I am part of my group. I publish and work with my superiors also, so we share information.
And in the information sharing, you know for a fact that we do not have daily rates when it comes to COVID-19 infection rates.
That's the point. We don't have daily incidence number as we speak. The daily incidence number is not available. So once we're able to get that, we will be able to do the situation for Ghana holistically and come up with concrete answers. So
in effect, it is we cannot say that Ghana has reached peak when it comes to COVID-19. It's impossible to determine.
Because the data for the evaluation for that particular answer is not available.
So we are wrong when we say Ghana has reached COVID-19 peak infection.
It depends on who is speaking. For instance, you talk of the Ghana Health Service Director, and I'm sure he has much more data as I have. So, but
you just told us that that data is not available.
Yes, that data has not been made available to us. You go to the website of Ghana Health Service, it is not there. That data is not there.
Okay.
Daily incidence data for Ghana is not there. Okay. But I don't know what Ghana Health Service, the director, what he has. He works with the team on the ground, and I think he might have much more inside information. But if you ask me of my model and of my perspective in modeling of COVID-19 as happens to all infectious diseases, without the incidence data, you cannot point up to peak.
So if without the incidence data, you cannot point out to peak, it means we probably might be rushing. But hold on a minute, because Dr. Michael Owusu, who's at the Kumasi Center for Collaborative Research, he's with us. He'll be helping us to understand, you know, they actually conduct the test. Maybe they've submitted the daily incidence data and thus is in a position to tell us whether or not from where he sits, he thinks that Ghana is reaching the peak status. Dr. Owusu, thank you very much for joining us again. We had challenged your line earlier, but tell us, I'm sure you, working within the lab, have a lot more information, and so you know that by now we should be happy as a people, knowing very well that we're getting out of it, isn't it, Dr. Owusu?
Yes, so I have listened to my colleague Emmanuel on the points raised, which are very important, significant things he has mentioned about what goes into a model and what will inform you to make a prediction. And every prediction you make is based on the quality of your data. It's the data that will inform you as to what to do. And you also realize that we have gone through a lot of difficulties for us and Noguchi in trying to clear a lot of backlogs. So there are two data out there. There is a data on when results are issued, and there is a data on when samples are collected.
Sure.
And there is a data on when lab results are also reported. So these are three things that are always churned out. So what you need actually is a data on the day on which the samples are collected. This is what is most important. Then you align that one to the laboratory results. When the whole exercise was starting, the framework of the data we had was more of when results are reported. So for the past 2 or 3 weeks, we have been working closely with the Ghana Health Service to try and realign all our data and point this to the date of sample collection, so that we'll be able to calculate the incident cases, the number of new cases that we record and or report every single day. This is what we have been working out for some time now. And we have not yet got to the point. So I'm not sure we have data of the daily incident case. We don't have that yet. I think that in the next couple of weeks, when we are able to realign our data, we'll be more confident to send this out to the Public Health Division. Then they can host it on the website for modelers to look at this and be able to model their data. So
Dr. Owusu, if we don't have daily incidence data, how come we're talking about reaching peak status?
Well, it's a bit difficult question to ask. From what I see and what I have observed, we do send data almost every day, but this data could be lagged behind, sometimes 2-3 days, sometimes a week ago, especially in the heat of the backlogs. And now that we have almost cleared the backlogs and Noguchi has almost cleared the backlog, we will expect that the data that will be coming from us ongoing will reflect the daily cases that come on the day on which samples are collected. So I think a lot has to go into this before we can begin to make prediction or talk about our peak times and when we are declining. So as my colleague said, the Director of Public Health may have more access information because the case investigation forms, surveillance forms are all sent to his unit. We only report results. I'm not too sure whether a team has entered all the case investigation form and have already realigned the data. I'm not too sure. But if that is available, perhaps it will be good for this to be hosted on the website so that modelers like my colleague Emmanuel de Graft can easily download this data and perform model. Let me just refer you to this. So there is a website that we call our human data website, which is a website that hosts almost all incident cases that are reported across the globe.
Okay.
So they pick their data from websites of different countries. If you look at them, they can tell you how many new cases Ghana is reporting. But this is based on how many new cases are reported on the website and not on when samples are collected. Even if you look at that, then you look at the trend of the data. It's not random. It is a bit erratic because you could have, for instance, on the 12th March you have 3, then as at 14th of April you have 70, and as of 30th of April you have 403, and as at 5th of March you have about 550. So it's difficult to use that to really tell your transmissibility in terms of the reproductive number to make any meaningful calculation, and based on that and make a prediction that indeed we have hit the peak and that things have leveled up. It's very difficult to use that data to really make any meaning. So I think that once the Ghana Academy of Art and Sciences are working towards it, we may need to perhaps give them some time for them to work through the data, to get fine details of the data, and then bring this out, bring the model, show this out to us, tell us what is happening, and if possible, host this data on the website, host the model on the website, show the graphics of what is meant by flattening, of what is the reference point for people to read into this and then make it a part of us. I believe the public is much interested to see more of this and then perhaps learn from this. So once such statements are made, I think that it has to be backed with evidence. And for me, because we don't see the evidence, this is why I believe the academic circle, people are worried that they don't seem to see the evidence of it. And if it's available, I think it will be very good for us to have a look at this. Then the modelers can also perform this exercise and then better inform us as to what is happening.
Now you made a very important point. I mean, while talking about the fact that, well, maybe the director has, the daily incidence rate and all, you also stated that it is difficult because of the, backlog, the lagging, daily testing. And so while you make, you send records daily, there's also the challenge of testing daily the number of cases that come to you. Doesn't that then tell us that nobody has that data now, and so the impossibility of the director having it and putting it out?
Well, it's difficult to preempt. We are only trying to speculate, but the director is in a good position to tell all of us. I believe.
But you also told us right now that it will be difficult to have the daily incidence rates because of the peculiar nature of our testing. That is not in doubt, because when we started, the number of samples that were brought to us daily were not all completed in that day, right?
Yes, I mean, you are right. Because of the difficulty we have with testing and clearing a lot of backlogs and entering the realigning data, this is what we have observed, and not only for us, but also from our colleagues from Noguchi. It has been quite difficult trying to clear all these backlogs. Once the backlogs are cleared, we are in a position to now give more real-time data, which will match the date on which samples are collected. But as I said, the director is in a position where he has more access to information. He has a lot of surveillance teams who work on a daily basis. What we will encourage is that if these data are available, which we don't have, perhaps it will be good that it is made for all of us to learn, and then for the modelers to especially model these and inform us. But until that is done, I think that from where I see, from what I see and from where I sit, I'm not too sure whether this is available, which will mean that we must be cautious and quite careful trying to say that we have reached our peak and therefore we are trying to level off. A lot goes into reaching the peak, and a lot goes into level off. I mean, countries that have reached their peak and are flattening their curve have put in measures to lift their sanctions, because it means that the transmissibility of the virus in terms of the reproductive number is perhaps below 1. Okay. If it's below 1, you can begin to ease measures and begin to let people go to school, because you think that there is a constant growth rate of the virus. New cases are not coming. So you are at a certain area that you think is not so much of a difficulty. People can go about their normal duties. So if you mention flattening the curve, it has influence on the measures you take. Okay. So this is why it is very important. If you talk about flattening the curve, it has a whole ripple effect. To tell you that action plan will have to change very quickly. But as I said, this primarily based on the quality of your data. If the data is not available, you may make a prediction 3 weeks behind, and you may be wrong, or maybe 6 months ahead, you still may be wrong. So I think that we need to be more cautious, and then try and let the Academy of Art and Sciences do this work. And I believe that when they come out with a model and they get the real-time data, it will inform us more as to where we are as a country. And that can inform the government as to what measures to take, whether to ease measures, to get people to go to school, to allow social gathering and to increase the numbers, or to open the borders and let people come in. All this has some impact. So the flattening of the curve will have to go along all these lines, and it has a huge impact on public health action. This is what I think we need to know.
So let's look at your daily test. Now, you are in the lab, you're testing daily. Samples come to you. The last time Dr. Silverken told us that you have sometimes 2,000, 2,500, 3,000 samples coming to you. Based on the test that you conduct, what has been the highest daily rate of infection, and when did you record it?
It will be very difficult to tell you now, because we have been doing a lot of work in testing and clearing backlogs. Even as in the next couple of minutes, I have to go back to the lab to work actively with the hope that by tomorrow we wouldn't have backlogs. So once we finish with this testing, our next job is the data team is trying to analyze and realign all our data to the point of sample collection. So we need to enter all the dates on which samples were collected, then properly organize our data. When this is done, then we have to share this data with the public health team and then the modelers as well, based on the advice from the public health division. Then they will be able to take this up and assist us. The data is a lot. We have done over 40,000 tests. And I need to look at it clearly, sort out those that are positive, sort out the dates, and then do some graphical works and determine the highest incident cases and the lowest cases. I have not yet done that, so it will be difficult for me to tell you. But I think that in a couple of once we clear all the backlog, the data will be made available, and I think the public health division will have access to this. And
so we certainly would come back to you, Dr. Michael Owusu, and also get to you, Dr. De Graaf Johnson. Dr. Michael Owusu is a virologist at the Kumasi Center for Collaborative Research. They've been conducting lots of research into, COVID-19 cases, whether we have cases or not. And then would also be, getting to Dr. Emmanuel De Graaf Johnson, who is with the Department of Actuarial Science and Statistics. Now, they've developed that mathematical compartmental model that is used in measuring, case of COVID-19 and also determining whether we've reached peak or not. This is Upfront. I'm Winston Amma. We'll be right back after this. Stay with us. So welcome back from that break, and thank you very much for staying. This is Upfront on Joy News. I'm Winston Amwa, and today we're joined by Dr. Michael Owusu of KCCR and Dr. Emmanuel de Graaf Johnson, who's at the Department of Actuarial Science and Statistics of the Kwame Nkrumah University of Science and Technology. We're assessing Ghana's peak status when it comes to COVID-19. Dr. Bedusa Akode, who is Director of Public Health of the Ghana Health Service, told us we've reached peak, and so all things being equal, we'll be seeing a decline. But let me just wrap it up with you, Dr. Michael Owusu. So you have to clear the backlog, and after clearing the backlog, you have to deal with, cases daily, and that is only when we can begin to say we have the daily incidence rate, and as a result, we'll be able to state that this is where we've reached. Realistically, how soon are you able to clear the backlog, and how soon would you be able to provide that daily incidence rate?
We hope that by tomorrow we should be able to clear all the backlogs from us. We've done close to 90% of the samples. So for tonight, we have a team that tonight we should be able to work this out. And we hope by close of the week, we should be able to realign our data and then be able to provide this to the Ghana Health Service Public Health Division on a real time, each and every day. So we hope this will be done from our part. And I know Noguchi has already started doing that, and we may follow suit very soon.
So from next week, we're certain that all things being equal, we'll get the daily incidence rates.
We hope so. And as a matter of fact, it's not just next week, but the point is that all the tests that we have done over the past 1 or 2 months, once we realign the data, it's possible to get the daily incidents, the daily new cases from 12th of March to date. So because you can now have each date and how many samples tested positive, and this can be hosted on the website, then you can be able to aggregate these numbers and do any form of calculation you want. So once we do that and the data is merged with Noguchi, I think that all other modelers will be able to have access and then make some good meaning into the nature of the data, into where we are and where we are expected to be in the next couple of weeks or two.
All right, thank you very much, Dr. Michael Owusu, who is virologist at the Kumasi Center for Collaborative Research. We're grateful you joined us today. Dr. de Graaf Johnson, so let's just wrap it all up. You've heard from your colleague, Dr. Michael Owusu. So for you, all things being equal, we're told that we'll be having the incidence rate from next week. That certainly would enable you to compile and determine whether we've reached peak or not, isn't it?
Exactly, that's the point. We'll be able to know the peak period, whether we are up to the peak period, we are there, or we've passed the peak period. And we'll be able to estimate the number of infections that will have occurred on the peak period, and that will be able to help us to project at the end of this pandemic, what is the size of the pandemic? How many population or percentage of Ghanaian population would have been infected?
Okay.
If this incidence data are available, it will help us to do all these projections, and it will be able to tell us if we are not there yet, when are we going to be there? What will be the number of infections? And then what will be the number of cases? The most important aspect is that due to the lag between infection and cases, if you are able to get incidence data and say, ending of this month on 31st of May is going to be peak period, then we know that within the next 14 days, our case is going to go up. Because when you reach infection, it will take a certain number of days before some will show some form of symptoms that could lead to hospitalization and so on and so forth. So we are hoping that this data becomes available. Then we will all be able to make these projections that will help in decision making.
All right, thank you very, very much for joining us also, Dr. Emmanuel de Graaf Johnson at the Department of Actuarial Science and Statistics at the Kwame Nkrumah University of Science and Technology. My name is Winston. I'm on behalf of Samuel Dami and the rest of the team. Thank you very much for joining us today on Upfront. Up next is Joy News Prime. Have a lovely day.